So good evening, everybody. Welcome back to the Journal Club. Delighted to have you all on board for what promises to be a very, very exciting session, covering really an important topic for all of us in Cath Lab. And I think important for all of us in Cath Lab, but also important for all of us who are in training and learning very much PCI, the importance of intravascular imaging. And, you know, we've got good data, and I think this is going to be a very interesting paper and discussion. So it gives me great pleasure that we are live today from Barcelona in Spain. Riccardo will be presenting the paper that we'll be talking about. And it's a great pleasure and an honor that we'll be joined by Professor Salvatore Brugaletta, who will be sharing his insights and expertise on this paper and this topic. So without further ado, Riccardo, over to you.
Okay. First of all, good afternoon to everybody. I'm Riccardo Rinaldi, an interventional cardiology fellow at Hospital Clinic in Barcelona. And I would like to really thank all the organizers of this Journal Club for the invitation to join this discussion with my mentor, Professor Salvatore Brugaletta. So as anticipated, let's see, okay. As anticipated, we are going to discuss the recently published intravascular imaging guided or angiography-guided complex PCI or Innovate complex PCI trial. So this trial was based on the fact that we know that patients with complex coronary artery lesions undergoing PCI have worse clinical outcomes compared to those without complex lesion. And during PCI, the use of intravascular imaging, both intravascular ultrasound or optical coherence tomography, can provide useful information about lesion characteristics, can help to select the appropriate stent size and stent landing zone, and to determine whether the stent is not well expanded or if there is stent edge dissection that are both associated with an increased risk of myocardial infarction, repeat revascularization, and stent thrombosis. However, previous randomized clinical trial addressing this topic suggested that intravascular imaging-guided PCI may reduce the incidence of future cardiovascular events in these patients. But the results of this trial were not considered to be definitive, especially because of the limited sample size, the short follow-up duration, or the inclusion of only highly selected coronary lesion subsets. So upon this background, the aim of this study was to investigate whether intravascular imaging-guided PCI could improve clinical outcomes compared with angiography-guided PCI in patients with complex coronary artery lesions. And this trial was designed as a superiority trial to test the primary hypothesis that intravascular imaging-guided PCI would reduce the incidence of target vessel failure compared with angiography-guided PCI. In this slide, we can see in detail the study design. So an appropriate sample size was calculated to be of 1,620 patients. And we can see also how a complex coronary artery lesion was defined. So as a true bifurcation, a Medina 111, 101, or 011, with a side branch of at least 2.5 millimeter in diameter, a chronic total occlusion as target lesion, a PCI for an unprotected left main disease, both involving the proximal left main or distal left main, even if not a true bifurcation, a long coronary artery stenosis with a predicted implanted stent length of at least 38 millimeter, a multi-vessel PCI involving at least 2 vessels treated during the same procedure, the need of multiple stents, at least 3, an in-stent restenosis, a severely calcified lesion, and an ostial lesion. And these patients were randomized in a 2-to-1 fashion and stratified by acute coronary syndrome and participating center to two different treatment strategies, an imaging-guided strategies versus an angiography-guided strategies. For patients randomized to the imaging-guided strategy, the choice to perform IVUS or OCT was left at operator discretion, and intravascular imaging could be performed at any step of PCI, but was mandatory after stent implantation to determine whether the stented segment was optimized. And if not, additional procedures such as post-dilation with non-compliant balloon or additional stent implantation was recommended, and another run of intravascular imaging was mandated. And then all patients were followed until 1 year after last patient's enrollment. The primary endpoint of the study was the incidence of target vessel failure, defined as the composite of cardiac death, target vessel-related MI, and any clinically driven target vessel revascularization. The secondary endpoint were the individual incidence of the primary endpoint and others such as target vessel failure without considering procedure-related MI, the composite of cardiac death and target vessel-related MI, any type of myocardial infarction, target lesion revascularization, target vessel revascularization, definite stent thrombosis, the total amount of contrast, the incidence of contrast-induced nephropathy, total procedural time, and also an analysis for total medical cost was planned, but not reported in the publication. Here we can see the study flowchart. So more than 5,500 patients across 20 sites in South Korea were assessed for eligibility, and 1,639 underwent randomization during approximately 3 years. 1,092 were assigned to the intravascular imaging-guided PCI group, whereas 547 were assigned to the angiography-guided PCI group. And the analyses were performed in the intention to treat populations. In this table, we can see all the baseline clinical characteristics of the study population, and in both in each of the two treatment strategy groups. And we can see that the clinical characteristics were pretty similar between the two groups. And we can note also that the study population was relatively young, with a mean age of 65.6 years, was most represented by men, 79.3%. Regarding the clinical presentation, it was well balanced between acute and chronic coronary syndrome. And finally, most patients presented with a preserved left ventricular ejection fraction, 58.7%. In this table, we can see all the discharge medication of the study population, and we can note how the most frequent P2Y12 inhibitors at discharge was clopidogrel in 74.3% of patients. Here we can see also that the procedural characteristics of the study population and between the two groups were well balanced, both in regard to the type of complex coronary lesion treated with PCI, as well as the number of vessels with disease between the two groups. And also we can see that the intravascular imaging, regarding the intravascular imaging device used, the most frequent was IVUS in 74.5% of patients, whereas OCT was used only in 25.5%. And this table summarized the main results of the study. So at a median follow-up of 2.1 years, there was a significant reduction in the incidence of the primary endpoint in the intravascular imaging-guided PCI group compared to the angiography-guided PCI group, 7.7% versus 12.3%, with an hazard ratio of 0.64. Regarding the secondary endpoints, there was a significant reduction also in the incidence of target vessel failure without considering procedure-related MI, in the composite also of target vessel-related MI or cardiac death, and of interest also in the individual incidence of cardiac death. There were no significant difference between the two groups for the other secondary endpoints. In this Kaplan-Meier for the incidence of the primary endpoint, it is clearly evident how patients randomized to the imaging-guided PCI had a significant lower incidence of the primary endpoint compared to the angiography-guided PCI. And similarly, in this Kaplan-Meier for the incidence of target vessel failure without considering procedure-related MI, imaging-guided PCI was associated with a significant lower incidence as compared with angiography-guided PCI. So in conclusion, this trial demonstrated that among patients with complex coronary artery lesions, an intravascular imaging-guided PCI was associated with a lower incidence of the composite of cardiac death, target vessel-related MI, or any clinically driven target vessel revascularization as compared to angiography-guided PCI. And therefore, this trial, the Renovat Complex PCI, support the use of intravascular imaging when performing PCI in patients with complex coronary artery lesions. Thank you very much for the attention.
Great. Thank you, Riccardo. That was a great summary and presentation. So great job there. So before we invite Professor Brugaletta for your comments, we'll just like to say that if anybody does have any questions relating to either this paper, this topic, or indeed we have an expert with us, you can either type them in the chat or just raise your hand and then you can ask your question live. So, Prof, if I can just invite you, please, to share your comments. Let's focus firstly on this article itself. What are your comments and opinion on this, please?
Sure. So I would like, first of all, to thank you all for inviting me and Riccardo. So to me, it's also a great pleasure, to help you in this journal club. So which is something that unfortunately due to my busy agenda, so I'm not able to join every time that you do. So we discussed, this paper together with Riccardo, and I guess that there are many points of discussion. So either regarding to this paper or regarding to the imaging stent optimization, which is this paper is talking about. So first of all, the first comment that we had, so this morning together with Riccardo, was about the sample size, So the sample size, is particularly of interest because, for the first time, so during the last years, so we may say that the investigators were really good enough, to get the real incidence of endpoint, which was exactly the same as expected. So it was 3.6 yearly. So, and indeed, so they had 3.6 yearly. So I will say that this is one of the first time that I remember during the last year that they exactly estimate the sample size. And this on one side, so may mean that, for example, so to make a PCI guided, an image guided PCI, so it's very, it's very reliable. So in the sense that we always can get the same percentage of events on one side, and on the other side, so that maybe is the maximum that we can get for imaging. So we cannot go beyond this 3.6 percentage of event. So that is, my first comment, which is, a little bit statistic. So having said that, I will say that this is the first time that so the imaging optimization is left to the operator. So the operator was free, to use either IVUS or OCT. So we used to have a trial which were making a sort of obligation for the operator to use either IVUS or OCT. So this is the first time that the operator is left, is free to use any of them. And results may be also applied to complex lesion according to the study definition. So although if we look at the baseline characteristics, so the patient was not so complex because they were young patients, so 50-50 between ACS and stable angina. And then, so the most important thing is about the impossibility to reach the imaging stent optimization according to the protocol that was defined by the investigators. So that on one side, so one may think that maybe the investigators were not good enough to reach this stent optimization, but the ones that we are always using imaging in our cath lab, so we know that it's always very easy to reach the minimum stent area of 4.5 or 5.5 according to OCT or IVUS. But when we go to the percentage of expansion of 90% or 80%, that is something that may be more difficult to reach, because the percentage of expansion is referred to the proximal or to the distal reference of the vessel. And sometimes we have some expansion at the proximal distal edge, or we cannot get, the normal vessel, the proximal distal edge. So that means that we have some plaque. So we are landed in a plaque. And that is one of the reasons why stent expansion of 90% or 80% may be difficult to reach, especially because in the protocol there is no mention. So if imaging was used also for preparing the lesion, for choosing the strategy of the lesion preparation, that to me is the key. So if you want to use a good stent expansion, because if we don't prepare the lesion, if we don't know the landing zone of our stent, we can get at the end not an optimal stent expansion. So to use stent the imaging before stent implantation is always the key to reach stent expansion, which was the reason why stent optimization was not reaching in all the patients. And so we were with Riccardo reading all the paper and also the supplementary material, but we didn't get data about where imaging failed in this optimization. So we know that imaging failed in this optimization in 50%, but we don't know where it failed. That will be something interesting to know, but unfortunately, there are no data. And one of the things that maybe is out of the paper, but to try to overcome this limitation of having, for example, the stent expansion not optimal, will that be to split the stent analysis into parts, distal and proximal, and then to use the proximal reference and the distal reference, So according to the proximal part of the stent, the distal part of the stent, which is an approach which is used in the one of the most recent OCT trial, the Lumiere 4. And last but not least, so one interesting also findings was also to see the reduction in cardiac death. So that, so to my knowledge, so one of the first time that we don't see only a reduction in target lesion revascularization, which is always, easy endpoint to reach when we use imaging in stent optimization, but we have always get a reduction in cardiac death. And our explanation was that maybe there is a reduction in stent thrombosis behind, so this reduction in cardiac death, because we know that when we have to adjudicate the event, so sometimes we get some death which are unexplained, and that for definition is cardiac death, but is also a stent thrombosis which is probable, and that so is maybe the reason behind this reduction in cardiac death. And very last comment, so is about the cost effectiveness of this study, which is not available yet, but we have seen that there is at least a secondary endpoint. So at some point, maybe later this year or next year, so it will be presented. That will be interesting to know, because I guess that if we do a pool here between all the ones that we are in this event, so we may see that the economic reason is always behind the fact that we don't use imaging when we do a PCI in our cath lab. And then, so it's up to you. So if there are any questions, so me and Riccardo will be happy, to answer.
Brilliant. Thank you so much for sharing those insights with this paper. Great analysis. So open the floor to everybody. Does anybody have any questions that they would like to ask our presenter or expert today? Perhaps I'll start with one question. So often a lot of people say that, it's not simply a matter of just opening the IVUS catheter guarantees you a good result. It's also the ability to interpret the IVUS imaging that you're seeing. And sometimes that can be a little bit difficult. So we're all, let's say, early career interventional cardiologists or fellows connected today. What advice would you give to people at, this sort of early stage of their career? That because when you approach IVUS or you see IVUS through an expert's eyes, there's so much information and data that you almost get information overload and you can get a little bit lost. So is there sort of 3, 4, 5 things that you would say as we're beginning our practice to always try to get from the imaging catheter?
Sure. So I guess the most important thing is that you don't do these things alone, because if you do all these things alone, so you will be, as you said, totally lost, because you are exposed to a lot of information. So I guess that so when you have to use IVUS or OCT, so you have to do at least 2 pullbacks, let's say. So one, is the preparation pullback. So, and in this preparation pullback, you have to analyze, to recognize very well the minimum lumen area, so where the lesion is located. And according to that, so you have to locate the landing zone of your stent. And then, so you measure the minimum lumen area at the landing zones, so the length of this stent that you will be implanted, and then you will get the stent sizing in terms of diameters, which should be the distal diameters, in terms of sizing, in terms of length, and also in terms of any optimization that you have to do, for example, for non-compliant balloon, in case you are giving a bifurcation, so that you have to do a pot, etc. And then that information that you can get from the PCI pullback is also about the type of plaque that you have to treat. So if there is a calcified plaque, so you may get also additional information about the extension of this calcification, not only longitudinal, but also circumferentially. And then so you may be more or less aggressive in terms of preparation. That, as I said, is the key for getting a good stent expansion. Then so you have a strategy, so you do the strategy, and at the end of this strategy, so once you have prepared the lesion, planned the stent, made any post-dilatations, and then you do the second pullback, which is the pullback to evaluate your result. And then so you localize your stent, so the proximal and distal landing zone. If you use OCT, so it's always very easy, because automatically the software so gives you the information about the minimum stent area and also about the expansion. Then the software also gives you the possibility to split the stent into parts, so to analyze the proximal and distal part separately or all together. And then according to the information that you get, either IVUS or OCT, in terms of minimum stent area and in terms of expansion, so you decide if you want to optimize the stent with a non-compliant balloon, what the same size, bigger size, etc. And so also you get information about dissection of the stent, malposition if you use OCT, and then you decide if you want to use an additional stent for correcting, for example, dissection, or an additional balloon for correcting malposition. So that is the most easiest part. So so don't forget that in 3 weeks, so we have also PCI, and then so we will have a lot of session about imaging, and then so you get exposed about how to use IVUS or OCT in your clinical practice.
Perfect, absolutely. So I know Aisha's got her hand up. We'll come to you in a second, Aisha. I think just to follow up from what you were telling us, there's a question from Tamim about when you're, lesion preparation and you've measured the diameter, the residual vessel diameter. Are you one-to-one sizing or downgrading for both lesion preparation and then stent selection?
Yeah, for lesion preparation, you have to do, maybe downgrading a little bit if there is no calcification, otherwise 1-1, so it's fine. And then for the stent, so you have to go from the external elastic membrane to the external elastic membrane. So it should not be a sizing based on a lumen. But so it's always better, if you are afraid, so to make a rupture of the vessel, so to downsize and then to correct after the IVUS or the OCT post-stent implantation. So if you see a downsizing, which should be correct, and then you correct after.
Perfect, thank you. So Aisha, can I invite you please to come on for your question?
Yes, sure, thank you. As a further to what you very correctly pointed out about the ability to interpret, perhaps Salvatore could comment on the generalizability of this study. Obviously, it was very well powered, but it was performed in a Far Eastern population where operators are so much more accustomed to the use as well as the interpretation of IVUS. Would you anticipate similar results, say, if this was replicated in a European population or any other population where the uptake of imaging in general is less?
Yeah, that's a very interesting question, because actually this morning we discussed it with Riccardo that the inclusion of the patient was, especially in specific centers in Korea. So we may say that most of the patients included in this study were coming from one single center.
Yeah,
so
more than half actually. Yeah, if I can comment, more than half of patients were from a single center, and 20 centers in South Korea, including only East Asian patients. So yeah, if you go.
That will be a problem, to generalize. I guess that we are sure that if we use imaging properly, so we can get the same results. But so maybe in European scenarios, or maybe different, because in Europe, so it depends from the center that you select. But so you may get a different result because, for example, there are centers that are not expert in imaging, and then so you can get different results. That is also the key for the principal investigator of the trial, not only for this imaging trial, but for any kind of trial. So to select the very good center, trying to avoid to have half of the patient coming from one center. There are, for example, trials which are making a stop of a center. So when they get, for example, more than 10% of the patients to be included in the trial, because they want to avoid that the results will come just for one center, but they want to come from all the centers, including patients in the trial.
Okay, thank you. Any other questions? Sorry, Tam is just asking, could you explain the cardiovascular mortality that came from this trial? You were mentioning stent thrombosis, I understand, right?
Yes. So we're also struggling, about this cardiac mortality, because so that is not an explanation, but what the explanation that we have done with Riccardo was about the stent thrombosis. So you know that every time that there is a death in a trial, so there is an adjudication committee which is trying, to adjudicate if this death is cardiac or not. So the easiest part is that when there are no cardiac identifiable cause, so the cause of this death is always cardiac. So because we don't know. And then, so when we have to define stent thrombosis, is always the same, because the stent thrombosis, if it is definite, if we have an angiographic identification of a stent thrombosis, but if there is a cardiac death, so which is not without an explanation, so that is a stent thrombosis which is probable. So we may say, but that is just our interpretation because we don't know, all the details of the trial, that this reduction in cardiac death is the same as a reduction in stent thrombosis, which is indeed in the trial. So if you see in the trial results, in the trial findings that Riccardo showed, so there is also a significant reduction in stent thrombosis. If we may say that both are more or less the same part of the two different parts of the same history, let's say. So this cardiac death is stent thrombosis. Don't forget that the sample size is not powered for demonstrating difference, but is sized for demonstrating difference in the primary endpoint. So this reduction in cardiac death is just an hypothesis generating and should be demonstrating in a trial powered for this specific endpoint.
I see. Okay. Any other questions? Anyone? We've got about 5 minutes or so left. If anybody has any questions or they want to come on and ask.
Hello, everybody. Can you hear me? I have just one final question in terms of perspectives. What do you think is the level of evidence that we further need to make the recommendation for the use of intravascular imaging stronger in European and American guidelines? Because up to now, if I'm correct, I think there is indication from the guidelines only in the PCI of the left main, but actually we know that there is a relevant role and this study with his limitation, but there is, however, evidence that somehow you can improve outcomes in these patients when you optimize the procedure with the iris. So what do you think in terms of perspective? Do we have to wait as evidence to further increase the level of evidence and level of recommendation for the use of intravascular imaging?
Yeah, that's also a good question. So I guess that the evidence is already there. So because so we have studies, so we don't have also this only this one, but we have many other studies in CTOs, meta-analysis showing that in complex lesion, not only in the left main, so imaging is always better. Unfortunately, I'm not involved in meta-analysis in guidelines, so I don't know where guys. So we'll upgrade this. And so we will see. So I guess that what we may do in clinical practice is to use as much as we can. So imaging, especially for this complex lesion, at least, no. So we may start maybe at the beginning when we are at the beginning of our learning curve with some very simple case, just to get acquainted about the technique, and then sort of apply in the complex case. So bifurcation, long lesion, for example, left main, of course, so that is no discussion, although I must say that we still see left main without imaging, so treated in our practice. And we will see. So I guess that the next guidelines so will come out in August about the clinical the vascularization, about the acute coronary syndrome. So they will come, so this August. So we will see. So if they will say something about imaging in PCI.
One question which I have, because working in different places, when you have STEMI with high thrombus burden, and there's this kind of attitude in some places, just be quick, get in, get out, open the vessel and do as little as you can, and try not to do too much post dilation, too much optimization, don't take more catheters. Can you comment on this scenario, sort of STEMI with high thrombus burden? Should we not? What's the feeling?
Yeah, so it depends from the thrombus burden, because in STEMI, so I guess that there are no doubt that you have to be fast. So you don't have to spend time to open imaging OCT iris unless you have something that you don't explain. For example, if you have a stent thrombosis or stent restenosis with a STEMI, so you may do it. So, but in case, for example, there is a huge burden of thrombus, so you don't see landing zone, etc., and then you implant a stent, so you may do that you implant the stent as better as you can, and then so you put the patient back in the cath lab after a couple of days, for example, after cangrel infusion, 2B3A, so they have still a room, I guess, because the thrombus burden is something that impede you to see the stent very well, especially if you use OCT. So actually, if you do it in the acute scenario, So with OCT, you don't see anything because the OCT is the best technique to see thrombus, but the thrombus is so impeded to see behind. So you don't see if the stent is well expanded or not. And with eye, also, sometimes you see something that you are difficult to interpret. So my best, tip is that you do your PCI as best as you can, and after a couple of days, you do the patient back in the cath lab, and then you do the imaging if you have still some doubts about the stent that you have implanted.
Great, thank you. So any last burning questions? Maybe we have time for one or two more questions. To say I'm learning a lot, and I'm sure many people are, so please do bring in your questions.
There's a couple on the chat.
So let's have a look. Marco, yes?
Yes, I have a question. About the stent optimization, which is the rule and your expertise with stent enhancement. So I use it frequently, almost routinely, and which is the possible rule.
Yeah, stent enhancement is a 2D technique, so it's impossible, to get area, and sometimes you may see some under expansion, but sometimes also give you not the right information. So the only scenario where I use stent, so this stent technique is when you do a bifurcation for seeing pot, kissing balloon, so to see that the strut is open. But for the rest, so I guess that the imaging is superior. So imaging is a 3D, and in this case, it's just 2D, and you have to do stent enhancement in 2 different projections, so very difficult to interpret. So sometimes there is calcium, and then don't forget that you have to get a balloon inside, so to get the imaging. Sometimes you have 2 stents overlap, and then you need a very long balloon, so to get the imaging enhancement, because otherwise you don't see anything of the stent.
Great. And then one question about, there's a lot of conversation about drug-eluting balloons, and particularly if you've got good lesion preparation or stent-like result, let's say, using drug-eluting balloon. Can imaging help us in that scenario of deciding to leave this vessel alone with just a drug-eluting balloon? I know some people also talk about if there's a little bit of a mild dissection, maybe imaging can help you assess the, the likelihood of vessel closure or not. Do you have any experience with this?
I don't have any experience. I must say that to me, physiology may use it, because I have seen, for example, Antonio Colombo making beautiful cases with the imaging post drug-coated balloon. Imaging to me, so maybe difficult to interpret, because as you said, so there is always a dissection. So with imaging, you will see a dissection, and then maybe you will be tempted to implant a stent. So that is not maybe a good choice. For evaluating the result of drug-coated balloon. But we will see. Because we need some studies there is nothing. So maybe at some point, so we will have an imaging-guided drug-coated balloon PCI or a physiology drug-coated balloon PCI.
So I think that my last question was going to be what's next for research with imaging, and I think maybe you've just given us the clues. So anyone interested in looking for that, maybe that's the avenue to explore. Look, I think we've just come up to time, so it just leaves me to, first of all, Riccardo, thank you so much for presenting that paper and going through everything in a lot of time. And Prof, thank you so much for joining us. Really, we appreciate it a lot, your insights, the invaluable experience. And as you say, for all of you, those who are connected, this conversation can go on and will go on at PCR. So absolutely lots to learn and coming up soon. And hopefully looking forward to the next session, and see you back then.
Thank you so much.
Thank you very much.
Thanks very much, Prof. Thanks.
Thank you.